Good afternoon. Today I'll be presenting an exciting and adventurous topic of TAVI and pure AR. First we'll discuss, we'll first discuss the issues, then see for a case presentation, see how do current generation valves perform, see the newer valves available, and then to conclusion. So what are the issues with TAVR in pure AR? One, these patients have no annular calcium. Now we know that the annular calcium is the backbone at which our new TAVR valve anchors. And if there is no calcium, it will be difficult to anchor. And the most of the annulus of these patients with AR are large, beyond IFU for many of the currently available valves. So it leads to higher valve embolization. And with the fear of valve embolization, we end up trying to do slightly deeper valve implantation, then larger valves, and there is a higher incidence of PPI. Large annulus, we try to oversize, and then that leads to a higher risk of annular rupture. And this is in a patient who is generally sick with heart failure and aortic dysfunction. So these all issues will contribute to the complexity of this TAVR in patients of AR. So let us come to our case. He was a 70-year gentleman who presented with multiple heart failure admissions in last 1 month. Echo showed a bicuspid aortic valve, severe eccentric aortic regurgitation, and moderate LV systolic dysfunction. This is a CT TAVR. You can see that the annulus is mostly non-calcific with a very large diameter. The perimeter was more than 100, valve area 750, and the average annulus diameter was 31 and above. So at this diameter, most of the valves won't be suitable. So how did we go about the case? So we have a bicuspid aortic valve with severe AR, with minimal calcium, and so we need to oversize to anchor the valve. Now how much to oversize? So generally, like say 25 to 30% for a self-expanding, and maybe 15 to 20% for balloon expanding. That's the current reference. Now a large annulus, the perimeter was 100 mm, beyond the IFU for a 34 mm, the largest available self-expanding valve. So we decided to use a 32 millimeter my valve with the extra volume for post-dilatation. With the patient being in LV dysfunction, we decided to use a general anesthesia in case we require a TE also, and the plan was to do a 80-20 standard valve deployment. So baseline angiogram, you can see that patient has a severe AR. As planned, we took the 32 mm valve. You can see here again severe AR. Sorry. So we went ahead as planned with the valve deployment. Now here, one specific trick is in a patient with pure AR, the valve tends to get sucked into the left ventricle. So the rule is to pace as fast as possible, as long as possible, and even after the valve is deployed, try to decrease the pacing rates slowly to see if the valve is getting embolized. Again, it's getting stuck again and again. Technical people, kindly check this. Yes. I can see on the laptop screen, but not on the. Yep, I can see on the laptop, not there on the screen. No, I'm not doing anything there. So for this case, we were okay. I mean, we went ahead with a slightly oversized valve, deployed the valve with a higher and faster pacing, and got a good enough result. You can see the diastolic pressures pre-TAVR were 37, which improved to 71 with no gradients either before or after, and the final gradient is around 2 millimeters of mercury, so a decent result. Patient did develop a complete heart block post-procedure and underwent a pacemaker implantation. Now this is just an example of one patient with TAVR in AR, but what does our current data say about TAVR in patients with severe aortic regurgitation? So this has been the largest registry from America with the Pantheon series, where patients were studied mainly with the point of view of seeing how much is the valve embolization in these patients. And you can see these numbers are really scary. The valve embolization happens in 10 to 15%. So, and the second valve implantation is required in more than 10%. Now, these are all very scary and serious numbers. The way we are trained to deal with TAVR in aortic stenosis, we know the numbers are like 98, 99 success rate with 1 out of 10 complications. And once we get into this AR, the complications go into a double zone. The 1-year MACE rate here was 25.7%. Now similar data from Europe, French, one of the largest French registry in Europe, they try to see the success rate of patients Yeah. To see how different centers perform, and the success rate was like 82% and 88% in the best highest volume center. But what does this 88 mean or 82 mean? In 82% it's successful, but when it's not successful, it's not like, okay, it's a CTO, I cannot cross the wire, I'll abandon. No, those 20% you are already committed that you will do a tower, and you are in a messy situation where you have to deal with either valve embolization or some serious complication. In this series also, the second valve implantation rate was 8.8%, again, almost reaching single double digit. And it's not just about implanting one more valve. These patients have adverse worse outcomes, as in the graph here below. It's just not about putting a second valve, but over a long term they do worse. Now, cardiac tamponade was 4%. Now, this is like while doing TAVI, we hardly ever see a patient with tamponade, and here the tamponade rate was 4%. It means they either had an annular rupture or a perforation. PPI rates were staggering 36%. And when they looked at composite primary endpoint about mortality, heart failure admissions, and reinterventions, at 1 year, 41% developed adverse events with 24% mortality. At 4 years, more than 50% were dead. So, and this is despite you treating those severe AR patients with a TAVI valve. So the numbers are really scary when you see for the current heart valve in severe AR. Now I just put this example to see how those 20% patients where we are not able to put the valve look like in the cath lab. Now you can see the upper corner, it's a self-expanding valve getting embolized, severe AR, patient develops a cardiac arrest. The other valve, these are all taken from literature, not my cases. Yeah. And then you can see right upper balloon expandable valve getting embolized towards LV. And then the last right lower corner, the valve getting dislocated in the LV. So these are all scary scenarios. So if when you are doing TAVR in a patient of pure AR, we should be familiar with these images, and we should be prepared to deal with these things if they ever happen. And they will happen if you are doing significant enough of numbers. And now let's try to understand the mechanism. If you see all these cases, the valve is getting embolized towards the left ventricle, downwards, not upwards. So when we think about valve embolization, what we imagine is like valve getting popped off into the aorta. But that doesn't happen, because when we deploy the valve, after valve deployment, say in systole, the LV pressure is 120, aortic pressure is 120. So the pressure dissipates. So it's not pushing the valve out. But in diastole, once the leaflet closes, the 80 mm pressure of aorta is going to push your valve down into LV, where the pressure will be 10 and 20. So the embolization happens mostly in the left ventricle, not in the aorta. And the reason is the valve is not able to get properly anchored. And that's where the solution lies. Now, understanding why valve embolization happens is among this group 1, 2, and 3. The group 2, where LVOT is flared, the diameter increases towards the apex. These are the cases where the risk of embolization will be higher. So, what are the solutions now? Now, we saw the most important issue in TAVR in pure AR is about anchoring. The valve embolizes and the highest rate of second valve implantation. So, we need to find a proper place to anchor the valve. So, what are the options to anchor the valve? One, we have annulus, or leaflets, or aorta, or a combination of these. Because we know that annulus has no calcium and is not able to do a good job at anchoring the valve. So that's why this new Gina valve triology system, you can see the design here. It has a special locator technology. That is, there are 3 locators which are present outside. So when you position the valve is in the hole, while these 3 locators are positioned in the cusps. And when the valve is deployed, the leaflet is clipped up between this locator and the valve frame. And hence it's going to anchor at the annulus and is going to clip the leaflets. So it's going to use both mechanisms for anchoring the valve, the annulus plus the leaflets, and does not rely on calcification, radial expansion, but clips the leaflets. Now, how does this valve differ from our current valves? It requires 21 to 22 French sheath, and it only works in tricuspid aortic valves. The sheath is slightly longer. It goes till the sinotubular junction, and then the valve is advanced. And the most crucial step in all these patients is trying to get these locators into the 3 sinuses. Like we take them down, confirm the fluoro and the TE to see that the locators are in the correct sinuses and the 3 sinuses. If it is not so, the valve is taken back, rotated clockwise or anti-clockwise, and then again is taken back. So the most important learning curve for this valve would be to adjust these locators to grip or clip the leaflets. But once valve is deployed, you can see here, the leaflets will be caught between the locator and the valve, and hence it going down or the valve embolization towards the LV will be lower. So what is the current world data on this valve? The Align AR just has been published, where they studied 500 patients. Inclusion was just high risk symptomatic aortic regurgitation. Among the important exclusions, it's mainly bicuspid aortic valve, obviously because the locator system won't work there. And what are the results? You can see most of the serious outcomes were quite low, and the valve embolization was around 1.6% during the procedure, and it became 2.2 on long-term follow-up. So very low valve embolization, which is the biggest fear in aortic regurgitation. And other primary safety endpoints, most of them look similar to what we get in TAVR in patient of aortic stenosis, except a very high pacemaker rates. Even in this valve, the pacemaker rates were nearly 36%. But when they looked at the pacemaker rates over different period, we saw that initially the pacemaker rates were quite high, but as the time went on, the pacemaker rates were lower, indicating that as the learning curve decreases, we learned that the valve need not be deployed as low, and the PPI rates came down. The 1-year mortality was 7.3%, far below than what was the goal. And you remember from the previous studies in the current valves, the mortality was like 24% at 1 year. Adverse events are like 40%. So this 7.3 is a significantly lower number. More than 90% had mild PVL, and more than 90% were in NYHA class 1 or 2 at 2 years of follow-up. And what does the future hold? Next we are conducting a randomized controlled trial of TAVR versus SAVR in patients of pure native aortic regurgitation. Now something to just discuss about what's new in the AR. Since till now we were following the guidelines which were based upon natural history studies done in 1980s and 1990s, because the only therapy available was surgery. But now once we have a percutaneous option available, we need to relook at these patients, relook the definitions, relook the criteria for valve interventions. And these patients with AR, now they behave into two categories. One is dilators, one is non-dilators. The dilators are the classical young people with bicuspid aortic valve, LV enlarges, dilates, so LVD won't rise. And these are the patients in whom all the current definitions of volume-based definitions of severe AR will be applied. But there will be a second group, elderly patients, females, hypertensive patients, in whom the LV becomes fibrosed or LV has lost the ability to dilate. And in these patients, even a moderate AR will cause severe rise in LVD. And so we need to define this second group of patients and to find out which patients will benefit most from the TAVR in patients of AR. Just to now, once we have a treatment or a solution available, we like to look into a problem more in detail, like we did with aortic stenosis. Like we know that in every valve condition, there are few patients who adapt. Like in AS, they develop LV hypertrophy, maintain the cardiac output at the cost of very high gradients, while the other group maladapts. LV just dilates and gives up, so no gradient. So we get this low gradient severe AS. Similarly, in AR, we have patients who don't dilate, where it won't satisfy all the volume criteria for severe AR. There are recent MRI studies which indicated that severe AR definition of 60 ml won't be enough for MRIs. At a volume of around 48 ml, LV starts getting fibrosed and dysfunctional in the elderly people. Now, just to conclude, older heart valves for TAVR, complication rates are exceedingly high, device embolization is still in double digits, very high PPI rates, and very high event rates over 1 year. So, with older diseases, TAVR is still possible, but requires very strict, stringent selection criteria. Plan, understand the annulus, understand LVOT anatomy, over size by 30% in self-expanding, 15 to 20 in balloon expandable, pace faster, harder, and as long as possible. Because when you deflate the balloon or when you release the valve, that is when you are going to know if the valve is going to stay there or is going to embolize. If valve is going to embolize, you need to be prepared to put a second valve. Don't lose the wire. And be prepared for second valve implantation. And be prepared for higher pacemakers. And dedicated valves are nearer than we think. They are almost completed the trial, now are in a randomized control trial phase. And it's likely that in near future we will get these valves available in India. And then the TAVR in AR should be possible in most patients. Thank you.